Yes, good afternoon, everyone. My name's Philip O'Connell, and I'd like to welcome you all to this latest update on emerging therapies for type 1 diabetes. And up front, I'd like to thank the St Vincent's Institute, the Westmead Institute for Medical Research, and the JDRF for all cooperating and supporting us, putting us on this event. And giving us the opportunity to reach out to you and talk about some of the new research we're doing. So we've got a pretty diverse panel, and although the majority of the talk today will be on islet transplantation, we do have Professor Tom Kay, who's the Executive Director of the St Vincent Institute for Research, and also the director of the Tom Mandel Islet Transplant Unit in Melbourne. He will be giving us an update of a new trial he's commencing for the prevention of type 1 diabetes or treating newly emerging or newly diagnosed cases of type 1 diabetes. They'll be then followed by myself and Natasha Rogers, who's the clinical director of the Islet Transplant Program here at Westmead Hospital. And our clinical trial nurse, Trish Anderson, who's here. We also are very privileged tonight to have two patients who've agreed to come on the panel, Diane Leader and Paul Jones, who've both had, from the patient perspective, the concept of having an islet transplant. And it'll be good to hear from them. We do have an opportunity for Q&A. Unfortunately, you won't be able to speak directly, but if you look at the tab at the bottom of your Zoom screen, you'll see a Q&A button. If you press on that and type in a question, we will attempt to answer it at the end. We do realise that those from New South Wales and Queensland do have another event on this evening, probably at 7:30, called the State of Origin. We promise you we'll be finished by then. And we'll get underway. So first up, I'd like to hand it over to Professor Tom Kay, and he will give us an update of his new clinical trial. Over to you, Tom.
Okay, thank you very much, Phil. Can you see my slides on the screen?
Yes.
Yep.
Yes, we can.
Great, thanks. I'll just...
Yes, we can.
Thank you. And I'll just see if I can find myself a pointer. Well, thanks very much, everybody. It's a real pleasure to be here, even though I'm in Melbourne where it's raining, but one of these days we'll all be able to get together for meetings instead of doing it like this. I'm going to give you a little bit of background about type 1 diabetes and tell you about an exciting new clinical trial that we're starting, which actually is being started in Melbourne. So there'll be a bit of FOMO because if you're based in New South Wales, it'll be difficult to participate in the trial, but I'll tell you about it anyway. Now, on this slide is a map of how people in the field think about type 1 diabetes, and I'll explain this quite slowly. So I want you to look at the background of this slide, and this is the pale blue color that I'm outlining here. And that's a graph of how, for the last couple of decades, we've thought about diabetes developing. It's got, you can think of it as a graph with time in years on the bottom here, and going upwards, the mass of insulin producing beta cells in the pancreas. And what happens in diabetes is that people are born with a normal number of beta cells, but at some point in time, the immune system becomes activated, starts deciding that it wants to get rid of the beta cells. And then that's what this slope is supposed to show, that the beta cells are in decline, and they're in decline because the immune system is destroying them, and eventually get to the stage where a diagnosis of type 1 diabetes can be made. And this measure of how much insulin the body is making, there's still some insulin at the time of diagnosis, but in the years following diagnosis, that pretty much falls to nothing and to no significant amount of insulin being made by the body, and all the insulin that people have to control the blood glucose has to be given by injection. And Phil and Natasha will talk about this, but once you have got very low levels of pancreatic beta cells, we can't do much at this stage to bring them back again, except by the magic of transplantation, and they'll talk about that. I'm going to talk about earlier treatments in what we call stage 1, stage 2, and stage 3 diabetes. Stage 3 is when the diagnosis has been made, and stage 1 and 2 are when the disease is developing, but it has not yet reached the stage where the blood glucose go up. We used to call this preclinical diabetes. It's going on for months to years prior to the onset of diabetes, and it can be detected by measuring abnormal blood tests called autoantibodies. And currently, they're mainly screened for in relatives of people who already have diabetes. In the future, we like to think the whole population will be screened for these antibodies, and the Juvenile Diabetes Research Foundation is right behind that. Now, up here is a list of some of the drugs that have been tried to see whether they can prevent the immune system damaging the beta cells. And most of those drugs have been tried in this stage 3 diabetes after the diagnosis of diabetes has been made. But a few have been made to try and prevent diabetes, and one of those was reported last year, a drug called teplizumab, and it was able to prevent diabetes by a couple of years. People who in the trial were taking the active drug did not have diabetes diagnosed for about 2 years after the people who were taking the placebo form, the inactive form of the drug. So this is very exciting and very positive, and gives everybody a lot of hope that drugs like this will be in clinical practice in the not too distant future. Now, we're interested in trying a family of drugs, a new class of drugs that's called the JAK inhibitors, and these come. There are a whole bunch of different JAK inhibitors being developed by the pharmaceutical industry, and some of them are shown here. And you might know people who are on them because they're already being used in some diseases, which we'll come to on the next slide. But there's certainly something that's being very intensively studied out there in many different diseases, and we want to do that in diabetes, where we think they might be useful. So the JAK inhibitors are tablets, and they've been approved for use in some already in some immune system diseases, including rheumatoid arthritis, inflammatory bowel disease, that's ulcerative colitis and Crohn's disease, and psoriatic arthritis. And they're being tried in a whole bunch of other immunological diseases. And we won't go through the details of this slide, but baricitinib in all the bars is in orange, and in most cases it's superior to the other drugs that are tried, except the only comparable ones are really versions of baricitinib or treatments that include baricitinib. So because these are sort of distant cousins of type 1 diabetes, they're also immune system mediated diseases. We're going to try this class of drugs in diabetes, and we've tried them a lot in animal models, mice that develop diabetes, and they're very effective at treating that. But surprise, surprise, we're not interested in curing mice of their diabetes. We're interested in improving diabetes in people who've been recently diagnosed with type 1 diabetes. So the primary objective of the study that we're going to do is to assess whether this drug baricitinib preserves what's called meal-stimulated C-peptide. So this is the amount of insulin the pancreas of patients make after they eat a meal. And this is in people who've got new onset type 1 diabetes within 3 months or so of diagnosis. We're going to assess the safety and tolerability of the drugs, although they've been very extensively trialed already in other diseases. And we're also going to look at a bunch of other things, including insulin dose, hemoglobin A1C, and so on. So we're going to enroll 83 patients who are aged between 12 and 30, so both pediatric and adult age group patients. This can be done in 4 centres, 2 adult centres, the Royal Melbourne Hospital and St Vincent's Hospital in Melbourne, and 2 paediatric centres, the Royal Children's in Melbourne and the Adelaide Women's and Children's. And half are going to be given baricitinib, half are going to be given an active drug, and the treatment will be given for a year. And we're just getting started. We've actually had the kickoff at these trial sites, and we're very grateful to the Juvenile Diabetes Research Foundation for funding the study and to Eli Lilly for providing the drug. So that's probably enough for my bit, Phil.
Thank you, Tom. And as I explained to you, you've already got some questions coming up, which is fantastic. And we'll answer those towards the end. So Nicole, if I could have the next slides, that would be great.
Gosh, there's some good questions coming in, Phil.
Yeah, I've noticed. Should be a tough session. So if I could have the next slide, thanks, Nicole. We've got a central controller here. That's just our institute here at Westmead Hospital. Next slide. Nicole, are you able to advance these? Oh yeah, so most of the people here would understand that the importance of modern day insulin treatment is to keep good control to prevent side effects, and side effects can affect multiple organs such as the kidneys and the eyes, cause cardiovascular disease, and also cause neuropathy. And actually, I'm not an endocrinologist. Natasha and I are nephrologists by training, and we also look after people with type 1 diabetes who've developed kidney failure. So fortunately, it's the minority of patients that do develop it, but a lot of people do get side effects. And it's important that we try and limit these. Next slide, thanks. Next slide. Yeah, so there's been a lot of studies that have shown that if you have better control, then you have less chance of side effects. And probably the first study of many to show this was called the Diabetes Control and Complications Trial. And here we have two graphs here, one on the left showing comparing people's control, which is the glycosylated hemoglobin, where you're trying to aim for a number of 7 or less, and the chances of getting retinopathy or eye disease. And you can see that if you've got good control, there's much less of a risk of getting eye disease. However, the problem with that for some people is that if you also look at the graph on the right, you can see that those same people are more likely to have severe hypos because they've got tighter control and there's less room for mistakes. And so that's always been a challenge, and it's worse for some people more than others. So if I could have the next slide, please. So when we're thinking of islet transplantation, the very sort of proof that this may actually work with good control was in people who already had kidney failure, and we gave them a kidney and a pancreas transplant. And as we have here, this is the first 50 people in a party we had for the first 50 people in Australia to successfully get a transplant. And these people here at this party all had normal blood glucose control and weren't taking insulin. So we'd cured their diabetes by giving them a pancreas transplant, which contains the insulin producing beta cells. The problem with this was that all these people had most of the complications, that they'd all had kidney failure, some had very bad eye disease and neuropathy. And therefore we thought, well, if it was safer and easier to give these cells or replace the cells that were destroyed rather than replacing the insulin, we may be able to get perfect control without the hypos. Next slide, please. So on the left, you can see when you're looking at the pancreas under the microscope, and the dark purple with the blue dots, you can see that's what's called the exocrine pancreas. So that's the pancreas that produces the enzyme that digests your food. And in the lighter purple areas are these pancreatic islets, which are the cells that secrete both insulin and glucagon and are responsible for controlling your blood glucose levels. Now, rather than transplanting the whole pancreas, what we want to do is isolate these cells in the lab, and that takes us to the photo on the right where we can see those isolated cells and just transplant those cells. So that means instead of, if I could have the next slide, so instead of transplanting the whole pancreas, you're transplanting the islets. And this is sort of a cartoon that describes that if we, at the moment, we're getting the pancreases from organ donors who are also people who have died and donated their organs. And we take the pancreas to the laboratory, isolate the islet cells, and then infuse them through the portal vein into the liver. And by just putting those cells, which is less than 5% of the pancreas, and without all the surgery, we can get near normal blood glucose controls and no more hypos. So that was the downside of this is you have to use immunosuppression to prevent rejection and also to prevent the autoimmune disease or your body's. So next slide, thanks. Next slide, thanks. Yep, great. So that was all well in theory, and we've done successful trials here, and we now have a multi-centre style. But I just wanted to take this opportunity to emphasise that you don't get to develop these new therapies without doing a lot of research and having a lot of support, both from Australian granting bodies and also from the Juvenile Diabetes Research Foundation. So this was just Tom Kay and his group's done a lot of research, but this is sort of a background of the research done at the Westmead Institute for Medical Research and our program, that it really began around 1990 when we started doing experiments with this in rodents. We were then trying to do research in using pig islets for transplantation. We're still doing research of that. We then, having gained expertise there, moved to isolating human islets in about 1998. And at about in 2000, or at the turn of the century, there was a big trial from Edmonton that shows human islet transplant could work. But we'd already had a decade of research here, and we were able to demonstrate and do our first islet trial, clinical islet transplant in 2002, which was only 2 years behind Edmonton. So we then teamed up with the group at St Vincent's in Melbourne and also at the Royal Adelaide Hospital, and undertook an Australian multi-centre trial, which obtained funding from the federal government with big support from the JDRF. That trial was successful and then had funding from what's called the National Funded Centres Program for small, high technology, low volume therapies, and brought it into the system. So we now have a national islet program. And we've now got a new trial that Natasha will be talking about soon. So next slide. So, and next, just hit it again. So if you look here at who we needed to transplant, we were taking people who had severe hypoglycemia. So on the left here, you can see that a lot of patients actually get a severe hypo at least once a year. But there is also, fortunately, only a small group, but a small group of patients who get multiple hypos, like 8 or 9 or 10. And this is really a big impost on their life. And it was this group who we thought needed treatment because they weren't getting successful treatment with their insulin. Next slide. And with islet transplantation, it's not that we get them back to being aware of their hypoglycemic episodes, but what we can do is take their blood glucose swings, which from what we see on the left to what we see on the right. So we can get poor control and get very good control, and therefore prevent hypos, and in many cases without insulin. Next slide, please. So this is my last slide. This was some of people from the early multi-centre trial who were successfully transplanted, and all these people had some period of being insulin independent. Ruth on the bottom left, she's our star. She was transplanted in 2009, is still off insulin. 3 of the people are still off insulin. and these people's lives were transformed. So Paul up on the right, he was a hairdresser and had to quit his job because of uncontrollable hypos. He was so impressed by his care, he went and did a nurse. He's now done a nursing degree and works successfully as a trained nurse up in Queensland. So that's it from me. And I'd like to now hand over to Natasha Rogers, who's director of the Westmead program. And she is going to talk about our new trial and the current updates on what's happening in islet transplantation.
Thank you very much, Phil. Can everyone, you can see my slides, I hope. Sorry, one moment. Right. So yes, I've taken over from Phil O'Connell as Director of the Clinical Islet Transplant Program here at Westmead Hospital, and Phil has obviously moved on to be the Executive Director of the Westmead Institute for Medical Research, but he's still an integral part of the Australian Islet Consortium. So I'm just going to go through some very basics about the program. Who can have an islet transplant? So really we're only thinking at this stage about adults. And as Phil mentioned, you have to have lots of episodes of hypoglycemia in addition to hypoglycemia unawareness, and this lack of awareness when your blood sugar levels drop to dangerous levels make this situation problematic and contributes to problems in terms of quality of life as well as significant risk of dying from hypoglycemia. We also consider people who have unstable diabetes, and particularly it doesn't improve with optimal care by an endocrinologist, for example, using an insulin pump and glucose monitoring. And you have to be in otherwise good health. The islet transplant per se is an actual procedure. You have to be on a number of different medications. You do have to have normal kidney function, no significant heart disease. And we do screen everybody referred to the program for these things. So the important thing to know is that islet transplantation requires a whole team to make it happen. And this starts from a surgical team who go and get the donor pancreases, which are from people who have sadly died and then their family has consented to that organ to be used. And our team goes out at all hours of the day and night to be able to retrieve the pancreases, and they bring them back to our laboratory, and we can process the pancreas under sterile conditions. And here you see on the right hand side we've got a islet isolation team, and everyone is dressed up, and it's done under sterile conditions because this is a clinical product. It is going back into someone, and so it needs to be done under the strictest conditions, and we test for all of that as well before we're actually able to release it from the laboratory to be used in a transplant setting. So this is another photo of the team again in the laboratory, purifying the insulin producing cells from the rest of the pancreas. And we end up with a little pellet. This is a test tube, and here we have a pellet of cells at the bottom, and we can identify that what we have in these cells are actually islets, and we can stain them with something called dithazone, and they turn up in this beautiful bright red color that you see here, and we know that we've got islets, and we can count them and see how many we have, because we need a minimum number to transplant that's based on per kilo body weight. And we can also test their purity and have a look and see that they're healthy and that they're going to function once they're transplanted into someone. And then we put the islets into a bag, and then we bring them to you or to the person having the islet transplant. And the transplant per se is, once we get to that point, is reasonably straightforward. We prepare the recipient for that. We bring the person in, they'll be on an insulin infusion. It's a procedure, so you have a general anaesthetic and cared for by an anaesthetist. We now undertake the procedure in the X-ray department, and we use specialists called radiologists to find large blood vessels in the liver, and we're able to access this blood vessel by a very small needle. And here you can see this is the blood vessel going into the liver, and we've injected dye, and you can see the pattern there of all the blood vessels going into the liver. And you can see that there's also basically a long tube there, and we infuse the islets just a bit like a blood transfusion, and they basically go into the liver and lodge within the blood vessels of the liver and essentially make themselves at home within the liver. That takes somewhere between 7 to 10 days, sometimes a little longer, and they start to produce insulin. So the average hospital stay is about 3 to 4 days, and during that time you have fairly intensive care from the nursing staff, as well as the transplant staff such as myself and the endocrinologist, and you start anti-rejection medication, and you can have up to 3 transplants at different times. So once you have your islet transplant, you need immunosuppression, so anti-rejection medication, as long as the islet transplant is working. And because of this, you need regular follow-up to check how the transplant is working, to check that you're on sufficient amounts of medication. We do regular blood tests to follow that up. And we're currently trialing different immunosuppression, so different anti-rejection medication. And I'm very happy to answer questions about this later. And so the new medication we think is going to make islet transplants last longer, and we think it has fewer side effects than the medication that we have previously been using. And the 2 people who we have on the panel tonight will also be able to answer questions about this, because they're receiving different types of immunosuppression medication, so you can gauge from them as well. So what are the pros and cons of islet transplantation? So as Phil has mentioned, you can certainly have significantly improved glucose control without having severe hypos. In a proportion of patients, you can come off insulin, which is, I can't speak for people with type 1 diabetes, but I'm sure that would be a life-changing event. Certainly the islet transplant procedure is much less traumatic than having a whole pancreas transplant. And the immunosuppression treatments that we have available to us are improving. So there's a different and less side effect profile. In terms of the disadvantages of an islet transplant, and these are things that we are working on both in terms of clinical trials as well as in the research laboratory, are things related to immunosuppression, because all of these medications come with side effects, and this can vary from person to person. You may still require insulin therapy, so you can certainly get rid of the hypos, but you still do require treatment because the islets don't necessarily completely control your blood sugar level. There's limited resources in terms of the number of pancreases that are available. We know that there's a limited number of criteria in which people are eligible to be able to donate their pancreases that will enable us to get enough islets to be transplanted. And we definitely know that islet transplants do not last forever. And we're certainly working on that to try and improve long-term outcomes. Just to give you an idea about some of the successes that we've had, I'm going to show you some results. This is from a hypoglycemia perspective. So just to orientate you with regard to this graph, this is the first 17 patients that received an islet transplant from the consortium study that was established. And so what we have is the hypo score taken over time, and time is seen here in this axis. And so here the blue columns are their hypo scores pre-transplant. You can see they typically reach the thousands. And as people progress through the post-transplant period from 1 month up to 60 months in some cases, so up to 5 years, we can see significant reduction in their hypo score. Not in everyone. In some cases, they certainly go down to 0, which is a marvelous effect. And certainly they are, for the majority of people, they are significantly reduced. Another bit of data from that same cohort of people that we studied looked at the overall insulin requirements, and this is in just the number of units per kilo per day. And you can see here on the left-hand side, pre-transplant, and then over the course of the your post-transplant follow-up, the amount of insulin that you require is significantly lower. And we know this happens in both cases, whether or not you become insulin independent. And you can see in the open squares, this graph on the right-hand side, in the open squares and the hash line, you can see that at about 9 months, we had a significant number of people who became insulin independent, and this was maintained. And even in those who continued to require insulin, this amount was significantly reduced compared to their pre-transplant requirements, which was beneficial and certainly contributes to less hypos being felt. So that's all I have to present, so I will hand back to Phil.
Thank you, Natasha. Now, we are lucky today to have Trish Anderson, and she's the trial nurse who's been with the iLEP program since its inception. So, Trish, over to you with some information.
Thanks, Phil. So as Phil said, I've been working here since 2008. My interest came from actually through my 3 children actually have type 1 diabetes. So when I came to the interview, that was my plug to get the job, and I'm still here, so that's good. So the referral process involves a letter from your endocrinologist, general practitioner, or diabetes educator. The main thing is that these people referring need to have a provider number to be assessed, so you can be assessed by that. And in that referral, if you can just ask them to include the history of your diabetes, how long you've had it, what issues you've had with it, what your treatment regime is, whether you're having an insulin pump or you're using injections, what monitor devices. There's more and more on the market now with the Freestyle, the Dexcom, the Medtronic. There's quite a variety of devices that are available now. The episodes that you have had of hypoglycemia unawareness, when they're occurring, what help you do need, whether you just need the help of someone local to pick up the symptoms that you're having, whether you need glucagon injections or whether you actually do need hospitalisation and ambulance care. And also the impact that it has on your lifestyle. It's not a competition of who's worst, who's best. It's how it actually affects you and how you think you could gain benefit from this. We do contact everybody that sends us their referrals and make initial contact. It's then passed on to Natasha or Jane Holmes Walker. So Natasha being our renal physician, our renal consultant, and Jane Holmes Walker is our endocrinologist. We work in collaboration with the endocrinologists that you actually have. We don't take over the care from that, and information that we do have in letters are given to your GP or the doctors at your request, and the continuing treatment that goes on through that. My contact details are below. It's just my name, Patricia Anderson @health.nsw.gov.au, so you're welcome to email me with those details. Any referrals I get are passed on to Dr. Rogers and Dr. Holmes Walker.
Thank you, Trish. So it's all very well to hear about it from the doctors and the medical staff, but I think it's quite different when you're the patient. So I think we're very grateful to both Diane and Paul, who've agreed to come on and talk a bit about their experiences and why they opted for this and how things are, and to give a full and frank discussion about what they think has been good and maybe what's not so good about it. So I think the plan was, I think we'd start with you, Diane, seeing you're there. So would you like to talk to us and just give us a bit of a rundown on how things have been going, say before you had the transplant, and what you feel as life is like now?
Well, before I had the transplant, life was very controlled by my hypos, because I had hypo unawareness. I developed type 1 diabetes when I was 38. I was in my 39th year. I had suspected it for 12 months previous, but it would never show. And I got an infection in that winter of that year, and my beta cells were all destroyed. I was on minute doses of insulin to start with, and still am. all the way through because I was very sensitive to insulin. If I had any more than 3 or 4 units, I would just go hypo. So my blood sugars were always doing this, up and down, up and down, up and down, which makes you feel absolutely crap. Get my thoughts in it. It was difficult. Oh, well, I never had a sweet tooth all my life, so the diet was no problem. Just the frequent testing. I would do 8 or 9 tests per day. And never know why things were always looking bad. But there were so many hypos in there that I just couldn't do anything about it.
And then you met me.
And then I met Trish, my local doctor at home. He went to a conference on diabetes where Professor Collins and the team were talking in Adelaide, I believe. And he came home and said, I found a solution for you because we were at wit's ends as to how we could do this. So he came home and then I met Tricia and I got onto the program and eventually had my first transplant in 2018 and my second transplant in May of this year. I have been off insulin now for over 12 months. It's a totally different lifestyle. My blood sugars never sort of go above 6 and they're rarely below 4. So I have I control new lifestyle. All thanks to the team. I don't know why I'm so tearful, but anyway.
So how about working? Did it change anything with that?
With work, yes, it did. Because there were a few staff members that could, I worked in the hospital at the stage. There were a few staff members you could tell if I was going low before I could, well, I really knew when I was going low. And they would intervene, my son and my husband. Could also recognise it. But now it's all good, so I don't have to worry about that. And they are much more, particularly my husband, because he found me one night after I started the pump in 2008. And I've only been on it for 3 weeks, just the pump, the electronic pump, and I was on 1 new doses. And I went to bed, my blood sugar was 9. And at 1 a.m. he found me unconscious. It took to 2 p.m. the next day to get my blood sugar back under control. They gave me 2 or 3 injections of glucagon, but because my temperature was only 35, I was not absorbing any. And it took a long time to come through. But since I've had then I went on to the sensors, and then I was relying on the sensors to tell me when I was having hypos. So it's basically reading by machines. And since the transplants, life has been totally different. Sorry, I'm so tearful. Just had a bit of a hectic day today. That's okay.
Yeah.
Yeah, I just dying now for my part of my treatment is 6 months post the second transplant. So I've had the glucose step test today, which is a bit of a draining episode, but well worth the exercise. And anyone that would even consider having a transplant is it's very ideal. You will have a new range of life. There are a lot of medications that you need to take in the beginning, but as it goes on, you're only basically on your anti-injections and the antibacterial medication, antibiotic. And then I'm just now on two medications, one in the morning, one in the evening for my diabetes, which is going to be. It's all good. But my life has totally turned around, and I have no issues now that I'm going to go to bed and may not wake up in the morning.
Okay. Thank you, Diane, for that. I think it's very brave of you to come on and give your story. I know that as you've been doing it, we've had a lot of people write in a lot of questions. So I think you've touched the hearts and minds of a lot of people online here. So thank you very much for agreeing to do that. So we also have Paul Jones. I think is Paul there? Yes, here's Paul.
Yes.
Thank you, Paul, for coming on. And would you be able to maybe give us your story about how things were before the transplant and since?
Yes, for sure, Professor Phil. My transplant, it was a necessity, I presume. I know it was a necessity because in the later stages of my diabetes, I was 28, and then I got my transplant. I was lucky enough to get my transplant at 54, I believe. Yeah, 54, and it is life changing. I didn't know about. I didn't know anything. I was ignorant to diabetes. Didn't really hear too much about diabetes before I got diabetes. So I don't know what failed. Was it my ignorance or the media system or the education system? I'm not 100% sure. But now diabetes is more prevalent around these days, so you hear a lot more of it. And so I was 28 then, and it was a long, drawn out life. It just seemed like a task earlier on, the earlier stages of changing to adapting to injections, and the injections increased over time, and so did my weight. My normal weight was pretty much, every time I weighed myself, I was about 76 kilos, and then it increased suddenly when I became a diabetic, and then I rose up to 96 kilos and ended up having 66 units of insulin plus. So my level reflected the insulin. Now, after I've had the transplant, I'm back down to my original weight of 75 kilos, and I'm crept up now that I've had the transplant to 78 and feeling great. Like I said, when I found out about diabetes, it was a shock to me and my family, because as much as I cared for myself, my family ended up caring for me more. And I didn't realise the impact that I was putting my family under. So it was a godsend to find out about the insulin cell transplant. I found out about it on the media. It was the first time I heard about it. It's a TV program, and my wife alerted me to it as well. And she said that it seems like a necessity to go, because I had more frequent ambulance call outs, and it was getting depressing, and I was stressed and detaching myself from life. It was a horrible cycle. It was a spiral down to, I don't know where it was going to go. So I found out, contacted Westmead Hospital, and ended up getting in contact with Patricia, went through an assessment, and Patricia guided me the way, supplied all the information that made the process really easy to understand. And then a year later, probably waited about a year later, and then I was called up when I was at a night shift, dropped everything, attended the hospital the next day, and received my first transplant from that day on. And I had my 3 transplants within a fairly short period of time, which was probably 6 months in total, I'm guessing, but I wasn't keeping the dates exactly, but I know the transplant dates themselves. I received the 3 transplants, and now it's just turned my life around. I've got a life now. Before I was diagnosed as diabetic by my doctor, I was doing triathlons, marathons, and I was a young, fit person, getting it all done. And now that I'm under control and I've had transplants, I'm getting back into that lifestyle again, more active, more exercise, stress levels have raised, stress levels have lowered, and especially my family, they don't talk about diabetes as much, but we're still aware of it, which is fantastic. And people are amazed every time I speak to anybody, even when I'm getting pathology blood tests done. They say, "Oh, what are you here for?" I said, "Oh, well, I had a transplant," and start to talk a little bit about it. And even them people are amazed. And I presume that those people would be caught in that loop, but obviously they're not. I spoke to other doctors, just general doctors, and they're very interested in the program as well. And they seem to have, they give me the illusion that they haven't heard anything much about it. So, just got, sorry, go ahead.
So how do you feel how do you handle the drugs you need to be on? Because that's sort of, at least from the medical side,
Yes.
a bit of a concern.
Yeah, the medical side, well, the drugs that I'm on, I've had no ill effects from the drugs or the operation. I was fatigued for probably about a year, definitely fatigued, and then slowly crept back to full health, feeling 100% and being a lot more active now after about a 2-year span. So I think it did knock me down a bit when I first had the transplant. Immunosuppressant drugs, Natasha and the rest of the doctors and the teams and professors are very diligent in getting my sugar levels checked and finding out about what my TAC requirements are, and it's all under control. And I've got no ill effects from the treatment or the procedure.
That's great. Thanks, Paul, and thanks for coming on. We really appreciate your input.
Thank you.
Hang on, I know we've got a lot of questions, so we've been bombarded on the question side here.
Yes, that's fine.
Which is great. So it's good to see it's got a lot of interest. So the first question was, someone asked, well, it's being recorded and will this be made available to the public afterwards? We certainly will endeavour with our IT team to put a link onto the Westmead Institute website where you can access this if people want to look at this again, or ask your relatives to come and have a look. So to the audience out there, yes, we hope you will make it available. So Tom, the first question's to you from your presentation, and it was someone asking can stem cells be differentiated to become beta cells or insulin producing cells, and then would you use these drugs to suppress type 1 diabetes in the body? So in other words, it's sort of a bit of a sophisticated question about what causes the disease and can we get the beta cells back without having to use organ donors and islets?
Yes, it is a sophisticated question, but it's a good question. Yes, so yes, insulin-producing cells can be made from pluripotent stem cells, but they're not yet in clinical use. With a transplant, there are two forms of immune reaction against a transplant. One is a recurrence of the disease process, the diabetes, what caused diabetes in the first place, the autoimmune disease, and another is transplant rejection. And by using stem cells, potentially you might be able to reduce the transplant rejection. That's sort of quite complicated to explain, I'd say. These drugs the drugs I'm describing could be used to prevent diabetes from recurring in the transplant. I just don't think we're up to thinking about that yet. We do think about it, but it's just not quite close enough to clinical practice yet. And people are thinking about other ways of stopping the immune system damaging stem cell transplants, including encapsulation, which I think is mentioned in a question a little bit further on, which is like putting the cells into a protective pouch that protects them from the immune system. And also using genetic modification of changing the genes in the transplanted insulin producing cells using the technology that just won the Nobel Prize for Chemistry called CRISPR. And so it will be necessary when stem cell transplants come along, it will be necessary to protect them from the immune system. That could be possibly done with drugs, but there are some other things that people are contemplating as well.
Okay. And Tom, there's been a few other questions. Kelly Shaw asked the questions in the patients in your trial who show good outcomes. Are you going to keep them on the drug, or what's the long-term plan with that?
Well, that's a good question too. We're not planning to keep them on the drugs post-trial completion. I think the idea is to establish whether these drugs are active and also to establish how long they will, if they do have a beneficial effect, how long will that last for, because we don't know how long it will last for. It's not really the idea of our study to think about people staying on a drug like this for the rest of their lives. That's one of the real challenges that we have to deal with. The idea would be more to stay on a drug for a period of time and see if that can provide a beneficial effect. So at this stage, we're using a year of treatment and seeing what benefit, trying to capture exactly what beneficial effect that will bring. But we're getting putting the cart before the horse here a bit, because we don't even know yet whether it will have a beneficial effect, and that's what we're doing the trial to find out.
And finally, Miriam asked, what do you find as new diagnosis? So what are the, I suppose, the clinical presentations that these patients will have that be eligible to maybe have a go in your trial?
That's right. So we talked about the age group being 18 to 30 years, and people have to start the medication in the trial within 100 days of diagnosis. The idea there is just to make it a reasonably homogeneous group. At diagnosis, there's still quite a lot of insulin-producing cells, and the goal of the trial is to protect those insulin-producing cells that remain, in a way to make the honeymoon period, this period around the time of diagnosis when people need very little insulin, to try and make that much longer than it would otherwise be.
Okay, thank you. Now we've also had quite a lot of questions from the about the islet transplant work, and I think there's several people asked questions about why we select the people we do. And in other words, I think the two major issues is why are we having adults rather than children, and also why we choosing people who have quite severe hypos rather than people that have good control. And I think that's related a bit to what Tom's alluded to. It's our concern about the anti-rejection drugs. So there are acute complications from these drugs, which normally can be managed well by people who are by the doctors who are used to using those drugs. But I think there are more serious long-term complications that we worry about, and they're often related to how long you've been on those drugs. So people are at risk of getting unusual infections or severe life-threatening infections. And they're also that people on these drugs for a very long time have a higher incidence of cancer than the general population. So these drugs do have risks, and we're still quite early stages of this treatment, and we're still trying to work out that to make sure that the benefits outweigh the risks. So therefore, we don't really think it's a good treatment for children, primarily because they'd have to be on the drug for a very long time. And also, we want to identify people who really have failed current therapy, which is, it's got a very long safety record, to make sure that we've got a group of people who we think the risks at least equal the benefits. So that's why we've taken people who really can't be controlled on other treatment, and it will stay that way for a little while until we have a better definition of where it fits in. And there's always the concern about the anti-rejection drugs, which if you do get assessed, that would be explained to you in great detail. So the other question is, to Natasha, I think, is why do we choose the liver for putting the islets, and why don't we put them back in the pancreas?
Yeah, that's a good question. And really the liver is used for a couple of reasons. It's accessible, and the blood supply is very accessible. And also the liver has very good blood supply that comes directly from the intestine. So all the nutrients that are absorbed into the bloodstream from the intestine then get directly delivered to the liver. And then it enables the islet cells to be able to respond quite rapidly to changes in blood sugar level. the reasons they're not put in the pancreas is that its location and there's no benefit, discernible benefit. What you really want when you give the islet transplant is for the islets to make a home for themselves, to settle down and to start working. And because the liver has such a good blood supply, that enables the islets to do that quite quickly. And some of the research that's been done here at the Westmead Institute has looked at other sites where you might be able to put the islets so that they perhaps might be accessible to monitoring. Maybe there's other sites that would be better and less traumatic to put into. And you know, Phil's team has looked at, is it better in skeletal muscle? Is it better, you know, under the kidney? That's still in the very early phases of research, but for the most part, the liver is the best location that we've identified.
So the other question, I guess, is assuming people are tolerating the immunosuppression drugs, what's the life expectancy of an islet transplant?
So I guess the expectation is that you should get 2 years. That's about average, 2 years of function for those who have insulin independence. We hope to be able to extend that. And there's obviously outliers on both regions. We get some people who have multiple islet transplants and don't necessarily respond as well as we would like them to, and there are multiple reasons for that. Sometimes issues related to the anti-rejection medication. And we're hoping that the new anti-rejection medication that we're using puts less pressure, I think, on the islets in terms of their attrition rate. And we also think that the new treatment we have has beneficial effects on the immune system. That means that the body is more likely to accept these islets rather than reject them. So we're hoping with this new medication, which is not readily available in Australia at least, and we are able to use it specifically for this trial in islet transplantation, is going to provide us with longer lasting islet transplants.
Okay, that's good.
Maybe I just comment there that, I mean, yes, some people get a couple of years of function, but as Natasha mentioned, there are outliers, and there are people who have their transplants for a lot longer than that. You know, I think both the Sydney and Melbourne groups have got people who've had transplants for 10 years or more now. So the life of the transplant can be quite long. And actually, people who do well over the first 3 or 4 years, will often maintain stable function for several years after that.
Okay. Yeah, that is true. And Tom is correct that we have had some outstanding cases, but and looking at the data that we've just looked at, the 5-year data and even at the 10-year data, that roughly from that trial, about between 50 and 60% can survive out to 10 years of function. So which is encouraging. So there was a question. There was also questions here about the organ donor, and does the health of the donor make a difference, but also is there an opportunity to use a source of cells other than organ donor? So in answer to the first part of the question, yes, there are things about the organ donor which does affect the ability to get a good islet preparation, which again makes it a more rare resource than it might otherwise be, because not every organ donor is suitable for isolating islets. And it does bring to the issue is, even though people get a remarkable response, we're only capable of transplanting very few people because organ donation is limited. So we do need, but what this studies and doing the islet transplant does help us from the medical side is identify a lot of things about where we need to put cells once someone's got diabetes, when we're replacing those beta cells. Yeah, we've found out at the moment at least that the liver seems a very good site for that. we do have to suppress the immune system, and we're doing a lot of study about the drugs we need. And we also identify the responses patients have. Now, if we then develop a new source of cells, all that information we've obtained will be very useful. And the two obvious sources of cells that people are working very hard on are stem cells. And there is a lot of work in that area, and I suspect there may be a stem cell related trial within the next 3 or 4 years coming out of the US. And there's been more data recently where people have been able to take fat cells and convert them into what they call islet organoids and have them protected against rejection. But also there's another side of people where people are taking pig islet cells and using genetic modification to make them look a bit more like human islet cells. So in other words, so the human immune system won't attack them as vigorous as they would a pig cell. And that data is coming along, and it's very likely that in Korea there'll be a trial of that sometime soon. So people are working hard on these issues, and certainly at Westmead, for instance, where with Wayne Hawthorne is working very hard on doing on looking at models of how we can use pig islet cells in humans. But we're not ready yet for clinical trials. So that's all in the laboratory and has really not reached the point of clinical application. But hopefully it will in the near future, because I think it was Tom who said it, that biology is better than technology. So if we can replace the cells that have been destroyed, that would be better than replacing the insulin. Other questions here is, after having a transplant, do you still need a carb count, or can you have a normal diet as any other healthy person with type 1? So Diane, I think you're the best.
One for Trish or Diane, yeah, that's
right.
Yeah,
that's one for Trish or Diane. Go, Diane, what's the answer to that?
You can have a normal, you can have what we call a normal diet. It's because I've been diabetic for that many years, it's very hard for me to just go out and eat a great lump of sugar. So I still watch what I eat, but you don't need to. You can have a normal. You don't have to be watching how many carbs, or unless you've got a weight problem, of course.
Okay.
Yeah, that's pretty common in our experience too, that people have spent so many years watching what they eat that it's not easy to give up all those disciplines after the transplant. It's interesting.
Yes, and then, so what the other question is, why do some people not reach insulin independence, and what is the percentage of this? So I think there are numerous reasons why people don't reach insulin independence. One is that that people have various degrees of sensitivity to insulin. So you heard from Diane's story that she was very sensitive to insulin, and some people, to get the same level of control, need more insulin. And that means you need more islets to be isolated and more to work. So sometimes it is a bit of a numbers game, but some people may lose some islets either when we transplant them, the shock of the isolation, and then some may be rejected. So despite the transplants, there is a percentage of people who don't get in insulin independence, but they do have these cells which are able to respond to swings in glucose. So if you add in a bit of insulin, especially if they get it from a pump, they often have much better control, very stable control with good HbA1c and no hypos. So even not perfect outcome can be quite life-changing for people. And about 60% have achieved some level of insulin independence. And Natasha, in the new study, that's a bit higher than that, isn't it? Would you say?
Yes, we've certainly had some remarkable results with just 1 or 2 islet transplants. So you can have up to 3. So I believe, Paul, you've had 3 and Diane has had 2. Look, we're very encouraged by that. And part of that may well be related to the anti-rejection medication that we're using.
Okay. The other one.
There's a question there about glucagon, Phil.
Yeah.
Well, we have from Shanna asking whether the islets transplanted produce glucagon.
Yes.
I think that it's not something that we routinely measure. And I think the jury's out a little bit about whether there is a huge amount of glucagon being produced. There's some studies being done in Melbourne by a young endocrinologist called Melissa Lee, and she's been looking at how much glucagon is made by transplanted islets, and it's a pretty small amount. I think the way that hypos get better, as most of you will know, glucagon can improve hypos. So you might imagine that transplanted cells making glucagon, that would help with hypos. I think the main way hypos get better after an islet transplant is this ability to switch off as the blood glucose drops, the islets stop making insulin, and so there's not as much insulin floating around in the bloodstream. That's the really fantastic thing about an islet transplant, and having your own control of the amount of insulin you make, that as the glucose drops, you can appropriately turn it off.
Tom, as in Tom in the audience, asked a question: do post-transplant individuals have an A1C that's near normal, say 4.2 to 4.6%? Well, it's normally not that normal.
How many? You'd have to ask how many non-diabetic people have got a hemoglobin A1C of 4.2 to 4.6 also.
Yeah, I think they're really having near starvation. But that, yeah, we can get that. Certainly success means it's got to be less than 7. And we have had several people whose A1C is near 6, which is considered the upper limit of normal.
And I think even less, you know, I remember the first patient we transplanted, Elaine Robinson, you know, at one point her hemoglobin A1C was mid-5s, and some of so they can get down basically to normal levels. That's the sort of goal, really, for that to happen.
So also, Tom, while you're there, there's a question by Andrew, but there's been various iterations of this question through it. Does the body naturally regenerate islets? And is there a pathway to using live donors? So I guess the first question is about islet regeneration. So that after they've been destroyed and you've got some left, can you get them to double up?
I think that's right. There's another question I think about whether there are medications, and suggesting a couple of medications which have been tried, in fact, including some quite common medications. Look, I think do islets naturally, do insulin producing cells naturally reproduce themselves throughout life in the same way that blood cells do, for example? It's thought that probably not very much in adult life, maybe to some extent in pregnancy. There's some expansion of the number of insulin producing cells in the body. Certainly there are higher insulin levels during pregnancy. But it's not clear really whether beta cells, you make more beta cells in adult life or not. People have argued the toss about that for a long time. There's certainly a lot of interest in the possibility of regenerating beta cells, and especially, and this touches on something that someone else asked, especially because it's been recently been found that even after many years of diabetes, some people still make a very small amount of insulin, suggesting that there are still beta cells there. And the idea is, could you make them into a bigger mass of cells? And I think that's one of those holy grails. It's not possible at this stage, but who knows in the future. One of the things I'm very encouraged by is how many scientific advances are made over the decades. They're not made in a short period of time necessarily, but when you think about how long Phil and I have been practicing medicine, a lot of things have happened in that time in a lot of different diseases. So that will continue to happen into the future.
You're giving away our trade secrets there, Tom. I do have a question here from Tony. It's, hi, I'm type 1 for 15 years and also take azathioprine, 75 milligrams. Would that be enough to prevent islet cells from being rejected? No, though azathioprine was one of the first anti-rejection drugs used for kidney transplants. It wouldn't be enough. And I guess there'd be, in answering the questions about, I guess what that question is alluding to, that if I'm already on immunosuppressive drugs for something else, does that affect my suitability? So certainly it wouldn't rule you out, and I guess it might be factored in if you're already on these immunosuppressive drugs and had your immune system suppressed. It may depend on the reason you're on that drug and how well your diabetes was controlled and other things. So it is an interesting question.
There's a really interesting one here from someone called Chris in the audience. She says she was on, he or she says, I was on a trial, well, I'm not sure why I'm assuming it's a she actually, it could be either obviously. I was on a trial for teplizumab in 2010 at King's in London. I was newly diagnosed. The trial was ended for efficacy reasons. I hadn't heard of it since. Looks like it's being focused on in stage 2 now. I mean, teplizumab's had a very interesting and an amazing history when you reflect on it. It's a drug that's been around for a long time, since it was first tried for type 1 diabetes in the early 1990s. It was developed by a scientist in the United States, Jeff Bluestone, working with Johnson & Johnson. And, but even more than that, it's a variation of a very old drug called OKT3, which was used in kidney transplantation back when Phil was a medical student. And so it's a drug that's been around forever. And you might well say, well, what's the excitement about it now? Because it's about to go to the FDA in the next 12 months, looking for approval for its use in to prevent type 1 diabetes. So after 30 or 40 years of drug development, suddenly this is the an overnight success over all that time. And it's had some trials over that time that have failed and some drugs that have been successful, some trials that have been successful. And I think it's a remarkable survival story that the drug is still possibly going to be in clinical practice. Certainly not the only drug that will make it into clinical practice. There's quite a lot of momentum for more drugs like teplizumab to come into clinical use in the relatively short term. In the next, these drugs have already jumped lots of hoops, and in the next five years or so, everyone says that, of course, but these drugs are on the cusp of being in clinical practice. So it'll be interesting to see how successful teplizumab is. But yes, it's amazing to me that it's been around that long. And similarly, another drug that's being thought to be, that's going to be probably useful in type 1 diabetes is one of the anti-TNF drugs, which have been used in rheumatoid arthritis for at least the last, I'd say, well, about the last 20 years. And it's amazing that they've taken this long to get on the NAC for type 1 diabetes. And it says something about type 1 diabetes not being the first port of call for the drug companies to test their drugs in.
Okay, so yes, so I just lost my place there. So
well, there are a few questions about LADA.
Yeah.
Maybe I'll have a go at them. I mean, LADA refers to type 1 diabetes coming on in older life, and first presenting to the doctor as looking like type 2 diabetes. So for some time, people are controlled with diet or diet plus the sort of tablets that people with type 2 diabetes have, but then it becoming apparent on the basis of tests and needing insulin that they've got this sort of variant of type 1 diabetes called LADA. We're not including them in our trial because it's a sort of variant. It's not really classical type 1 diabetes. And I guess in all clinical trials, you're trying to make the trial successful and you're trying to recruit a sort of standard patient, and LADA is not quite standard enough to be included in our trial.
Okay. Okay, so yeah, so there's a few other questions I think we can answer quickly. One is, in studies so far, are there more successful whole pancreas transplants than islet transplants? So I think that is a good question. And at least in our centre, we do both pancreas transplants for people who have kidney failure, and they get a kidney and a pancreas. And then there are patients who have islet transplants who have normal kidney function. And Natasha, it'd be fair to say, I think we feel that the islet transplant gives a better outcome if you've got normal kidney function, but the pancreas transplant works really well if you're getting the kidney from the same donor and that you need a kidney transplant. Do you want to have a shot at that one?
Yeah, so that's, I mean, look, I think you've encapsulated it. So when we do kidney transplants, getting the pancreas and the kidney from the same donor, so you receive both at the same time, and you have the same immunosuppression. It's not a small undertaking, both in terms of the surgical expertise required to perform that operation. It's complex. There are significantly more risks associated with transplanting a whole pancreas, and there is a significant acute loss of the whole pancreas graft early on. And that can be a devastating complication of that procedure. And we rarely here at Westmead do a pancreas alone transplant. Sometimes we do a pancreas after kidney, so people who've had a kidney pancreas together and the pancreas transplant has failed can come back later. But really, in terms of the length of hospital stay, simplicity of the procedure, and now with the success rates that we're having, I think the islet transplantation is favoured over pancreas transplant.
And I just say that I think the results that you've been getting in the new trial, Natasha, are amazing, and I think it'd be great to see how that pans out, because it just seems like a big change from how things were going before that.
Look, it is a significant change, and we're really very encouraged by the marvellous results that we have been getting. They are preliminary, so we remain cautiously optimistic.
So there's a few questions I think we can answer on some logistical issues. So there's a few people asked about the cost, and straight up that if you're a Medicare card holder, so a permanent resident or an Australian citizen, then there's no cost. This is covered by the federal government and state governments. So there's at the moment no charge. There is a bit of a co-payment for the drugs, but the majority of the cost of those is covered by the trial costs. So at the moment, it's on your eligibility, not on your ability to pay. The other question was said, is the trial only accessible at Westmead? Well, there's 3 centres where you could go to. So there's one at Westmead, there's St Vincent's Hospital in Melbourne and Royal Adelaide Hospital. And people in other states, this is a national program. So the person was saying from the Gold Coast, and we've actually got 2 or 3 people actually from the Gold Coast who have been transplanted at Westmead. So it doesn't matter if you're in, and we've had people from Western Australia and in fact, every state in the country. So where you live is not an impediment to being eligible for the trial, nor is there your ability to pay. And I think there's another question about how many islet transplants are being carried out annually. Natasha, what would be, it's about 6 to 8 or 10?
So at Westmead, we do 6 to 8, and that can be in several in the same person. I think Paul mentioned when he was talking how he had his actually back to back. Paul, I think that you had all of your transplants within 3 or 4 months, and every time I saw you in clinic, I said, oh, we'll just let this one settle, and then almost the next week you got a call to come back in for subsequent transplants. So it can happen with rapidity if we get the right set of donors. Obviously, the current pandemic climate has significantly impacted on the program in terms of the availability of donors, but we're hoping that this will slowly change over coming months.
Okay. So there was also another question around islet encapsulation, which I know has been done experimentally to see if you can protect the islets from the immune system and thereby not need immunosuppressive drugs. So this experimentally is attractive, and you could see why it's being pursued, but as a clinical procedure, it's so far failed. And one of the problems is that when you encapsulate the islet, you not only keep the immune cells out and stop it from being destroyed, you also prevent essential nutrients that the cell needs from being absorbed. And the cells sort of become, and also they don't get good access to oxygen. So the cells become hypoxic and sort of starved. And if they do function clinically, their function's not been for very long. So unfortunately, at this point in time, at the current state of that technology, it's not been really successful in the clinic. And I know one of the people did mention a company in France that's pursuing this, and that Natasha and I and Tom are aware of those studies, but it's not ready for prime time at this point in time. So I think it's time to sign off and hand over to the rugby league soon. So I would like to thank you all for attending. And if I didn't answer your question, we apologise for that. You could send in emails and we'll try and get back to them. We will endeavour to make the recording of this available publicly from our website. So we'll reach out to you individually and let you know about that. And I also would like to thank both Sir Tom from St Vincent's Institute at the JDRF and the Westmead Institute for Medical Research for coming together to put this on. So, and thank you all for attending. This research, the research that brought this was Australian research, and it has been supported generously by both the Australian government and the Australian public. And I'd like to thank all of you who've been associated with the JDRF, and I hope you'll continue to support medical research, both in your intellectual support, but also monetarily if you're able to do so. So there are many opportunities for that, and we will endeavour to try and make things better for people with type 1 diabetes. And we're almost up to 100 years since the discovery of insulin. So I hope within the next 10 to 20 years, we'll have a situation where people are cured of diabetes and we're not talking about treatment, but that's for the future and the future of medical research. So thank you all.
Phil, can I just chip in and say thanks a lot to Nicole for corralling us and organising it and making sure that we got on the call in time. And thanks very much to you for having the idea of organising it, and Trish and Natasha and so on, because I think it's been a terrific session and the audience have been great with their questions. Fantastic.
No, it has been good, and funnily Zoom does work well there. In particular, I'd like to thank Diane and Paul who've come on. It's not easy to come onto a public forum like this and talk about your medical condition. I think it was very brave of you to do so, and we appreciate it very much. And we wish you all the best. So thank you very much. Good night all, and everyone stay safe, as they say in these times. Thank you very much. Bye now.
Thank you.